So hello everybody, today we will be discussing on the topic of cardiology, that is constrictive pericarditis and restrictive cardiomyopathy. So why are we discussing this topic? That's because the clinical manifestation of these two entities are quite similar in the way that the clinical manifestations are of predominantly right heart failure signs. The patient presents with pedal edema, abdominal distension, raised JVPs and swelling of the face, and they have a preserved LV ejection fraction. Constrictive pericarditis, and it's important to differentiate these two conditions because the constrictive pericarditis is a potentially reversible condition and reversible cause of heart failure, whereas restrictive cardiomyopathy has very limited therapeutic options. Now the word itself, the diagnosis itself states that constrictive pericarditis is something like an external force which is constricting the filling of the ventricles, and restriction is the patient has internal restrictions or internal limitations in the LV filling. So to understand these two conditions and to differentiate amongst them, we have to understand the normal cardiac hemodynamics. So I'll just brief about the normal cardiac hemodynamics here. Diastole and systole are closely linked to one another, with the preload is provided by diastolic filling, which is necessary to generate the stroke volume. Now diastolic filling, it depends on many factors. Some of the factors are extrinsic to the cardiac chambers and other factors have intrinsic myocardial properties. So the factors which are extrinsic to cardiac chambers, which include the pericardial restraint, the chest geometry and the loading conditions which is imposed upon the heart, and the intrinsic myocardial properties includes the viscoelastic forces, the myocardial stiffness and the stress strain relationship. So if you see ventricular diastole, so it's broadly divided into three components, that is the early rapid filling, a late diastolic filling and the last phase of atrial contraction. So the early rapid filling, the components or the sequence of events which this occurs, and the factors which are responsible for early rapid filling includes the early ventricular relaxation phase, and this causes a driving pressure across the mitral valve, and that causes the blood to be shifting from LA to LV. In the late diastolic filling, there is continued LV relaxation. Along with that, the pericardial restraint here comes and acts. So the pericardial restraint is a factor which is influencing your late diastolic filling more rather than the early rapid filling, and the final phase is of atrial contraction. So in both of these conditions, the diastolic dysfunction is the hallmark. There is elevated ventricular filling pressures and the mean atrial pressures are elevated, and in constrictive pericarditis the early rapid phase is preserved, that because the myocardium is relaxing very properly and the pericardial restraint part, as I had mentioned, it presents in the late diastole. So the early rapid phase is preserved in constrictive pericarditis, whereas in restrictive cardiomyopathy it is a pan-diastolic impairment because the muscle itself is abnormal, so it doesn't relaxes properly. So if you see this diagram, it is very nicely explained in this diagram how the diastole phase of the cardiac cycle acts, and there is a ventricular pressures and atrial pressures which are seen, and the mitral valve flow signals are seen as well. So after the systole is completed, there is a phase of isovolumic relaxation time, and here the ventricle relaxes, the atrial and the aortic and the mitral valve are closed and the ventricular pressure falls. Now as the atrial and the ventricular atrial pressure rises and the ventricular pressure falls, the cutoff point where the mitral valve opens, and that's where the rapid filling phase occurs. And then there is a phase of equalization of LA and LV, and then there is a final phase of atrial contraction where the LA pressure increases and the final emptying of LA happens. So the early rapid filling is responsible for 70 to 80% of the LV filling, and then there is a phase of diastasis, and finally then there is a atrial contraction. So if you see the Doppler flow across the mitral valve, the E wave is what is the early rapid filling, and then there is a phase of diastasis, and then finally you will get the A wave, which is the wave of atrial contraction. So if you see the respiratory flow hemodynamics, which is what we'll see and differentiate between the constrictive pericarditis and the restrictive cardiomyopathy. So pericardium, it encompasses both the ventricles, right atrium and most of the left atrium. The pericardium covers this much portion of the heart, and most of the SVC and IVC are not intrathoracic, and as such they are unaffected by the swings of the intrathoracic pressure. During inspiration, the diaphragmatic descent results in a decrease in the intrathoracic pressure, which is fully transmitted to the cardiac chambers and the pulmonary veins, but not in SVC and IVC. So with no change in systemic venous pressure, the drop in this intrathoracic pressure, it augments the right heart filling. Now that's what happens normally. The pulmonary veins are entirely intrathoracic, and therefore there is a uniform decrease in pressure in the pulmonary veins and the left-sided cardiac chambers. So the left-sided filling does not significantly alter during respiration, whereas during expiration the right-sided filling decreases relative to the inspiration, and whereas the left-sided filling relatively remains constant or it increases very slightly. So now we come to the mechanism in constrictive pericarditis. So constrictive pericarditis, it's a pathological entity where there is an encasement of the heart by the thickened, fibrous and sometimes calcified pericardium. So here the most common etiology in our Indian subset is tuberculosis. And the next most common are the ones which are bacterial pericarditis, then a previous surgical intervention, a radiotherapy past, and then there is some neoplasm and uremic pericarditis. So what are the hemodynamics of constriction? The primary hemodynamic consequence of constriction is the limitation of total volume of blood that can be accommodated by the heart during diastole across the respiratory cycle. And there is equalization of left and the right side cardiac filling pressures. That's because there is encasement of the heart throughout by the pericardium, which is thick and rigid. So this rigid pericardium isolates the cardiac chamber from the intrathoracic pressure sinks, which I have discussed previously. So this causes an under-transmission of those reduced intrathoracic pressures to the cardiac chambers during inspiration, and this inspiratory reduction in the pulmonary capillary and venous pressure, it reduces the flow between the pulmonary veins and the left-sided cardiac chambers, and the rigid pericardium with its relatively fixed intrapericardial volume, it has a reduced LV filling which allows for an increased RV filling. Now this is accompanied by inspiratory intraventricular septal motion towards the LV. A converse is seen in expiration. So with expiration there is a rise in the intrathoracic pressures, and also the pulmonary venous pressure increases. This augments the flow to the left side of the heart, increased left-sided heart filling with a relatively fixed intrapericardial volume. It pushes the intraventricular septum towards the right, and thus the reduced RV filling and creating an expiratory diastolic reversal, which is transmitted back to the hepatic veins, which can be clearly seen on echocardiographic Doppler, where you will feel an expiratory flow reversal in the hepatic veins. This diagram nicely explains the schematic diagram of the flow velocities in constrictive pericarditis. So in inspiration there is decrease in the LV filling, which results in a leftward septal push because of the RV filling with augmented flow in the RV, and the opposite as that happens during expiration. Now the accentuated early rapid ventricular filling occurs because of the high atrial driving pressures and unimpeded ventricular relaxation, because the ventricular relaxation in constrictive pericarditis is normal. So there is a sudden rapid rise of pressure which follows from the pericardium restraint after the early rapid filling has happened. So this accounts for a very rapid Y descent on the atrial pressure waveform and a square root sign which is seen in the ventricular pressure. Now remember, this square root sign and a rapid Y descent are also there in restrictive cardiomyopathy. So the preserved atrial relaxation as well as an exaggerated ventricular longitudinal contraction, it results in an exaggerated X descent on the atrial pressure tracings. Now this is not going to be seen in restrictive cardiomyopathy. So an exaggerated X descent with a very rapid Y descent is what is seen in this diagram. Also you can see the red line is what is the atrial pressure curves, and the blue is what is the ventricular pressure curve. So you see a very sharp Y descent and an exaggerated X descent, and this is classically seen in constrictive pericarditis. And you will also observe a very a rapid early filling wave which is seen in LV pressure tracing, and this is what is known as the dip and the plateau sign. So the LV filling, it's very rapid, and then if it is more than 7 millimeters of mercury, then you will it's very specific sign for constrictive pericarditis, the early rapid filling wave. Again, when you do a cardiac catheterization and you see the pressures of LV and RV simultaneously, what you will feel and observe is there are changes during inspiration and expiration, as I have already mentioned, that with inspiration the RV pressure and RV filling is more. So the RV systolic pressure is higher and the LV systolic pressure would be lower. So if you shade the area under the curve from RV to LV during inspiration, and then if you shade the area under the curve of RV to LV during expiration and then divide the two, what you get is the systolic area index. Now obviously in constrictive pericarditis this area would be more than 1.1. So the more than 1.1 is highly sensitive and quite specific. It's almost about 100% specific for identification of constrictive pericarditis. So this index is very significantly higher in patients with constrictive pericarditis as compared to the restrictive cardiomyopathy. So now we'll go to understand about restrictive cardiomyopathy. So unlike the complex play of the pulmonary and the systemic pressures which are associated with constrictive pericarditis, restriction cardiomyopathy is a result of abnormalities which are intrinsic to the myocardium, and this doesn't change with respiration. So as with constrictive pericarditis, there is an early rapid filling of the ventricles during early diastole. That's because of the high atrial pressures, and there is following which there is a limitation of filling from the stiff myocardium. Now this does result in a prominent Y descent in the atrial pressure curves as well as a square root sign on the ventricular pressure curves. The stiff non-compliant ventricles are unable to easily accept the additional increments in volume during atrial contraction, and thus the contribution from the atrial contraction in cases of restrictive cardiomyopathy is very minimal. So here you can clearly see the waves of the atrial waves. You will see a prominent Y descent, but there is no X descent. X descent is blunted. So unlike constrictive pericarditis, the X descent is blunted given the pure atrial relaxation and the limited descent of the annulus towards the apex. There is no discordance between the intracavitary and the intrathoracic pressure. So these are the tracing of the simultaneous LV and RV which we'll see in restrictive cardiomyopathy. You see not much change in the pressures between the RV and the LV during inspiration and expiration. It's relatively constant, and there is no evidence of enhanced ventricular interdependence which was seen in constrictive pericarditis. However, you can observe that the square root sign is present here also, and the end diastolic filling pressures are very high in restrictive cardiomyopathy. So in both the disease, the catheterization demonstrate early rapid diastolic filling with elevation and equalization of end diastolic pressures. However, if you see a pulmonary hypertension, if the patient has significant pulmonary hypertension, it clearly goes in favor of restrictive cardiomyopathy. However, few patients of constrictive pericarditis do have pulmonary hypertension also, and this can be seen a rapid filling wave with a height of more than 7 millimeters of mercury. As I previously mentioned, it favors constrictive pericarditis. So to summarize, a prominent Y descent may be present in both. A paradoxical pulse, which is the pulse which has a low amplitude when the cardiac activity is constantly present, and this happens more with cardiac tamponade, but it can be seen with constrictive pericarditis also. So it's seen in constrictive pericarditis in about 30% of the cases, but it's absent in restrictive cardiomyopathy. Now you can even find a pericardial knock which is present after S2 in constrictive pericarditis. It's a high pitch quality sound which can be seen in constrictive pericarditis, but it's absent in restrictive cardiomyopathy. If you see the LV and RV sided filling pressures, they are equal in constrictive pericarditis, whereas you will find some amount of difference in the restrictive cardiomyopathy. The filling pressures are very high in restrictive cardiomyopathy, whereas they are not that high in constrictive cardiomyopathy, constrictive pericarditis. The pulmonary artery systolic pressure, if it's more than 60, it favors RCMP. A pulmonary venous flow, the systolic flow is blunted and the diastolic flow is increased in RCMP, that's in restrictive cardiomyopathy, but there is normal systolic and diastolic flow of pulmonary venous flow in the constrictive pericarditis. The hepatic veins, they show a expiratory flow reversal with constrictive pericarditis, whereas they show an increased inspiratory respiratory flow reversal is what is seen in restrictive cardiomyopathy. The square root sign is present in both, but it's more predominant in constrictive pericarditis. Now, if you see the Doppler differences in between them, the mitral Doppler inflow patterns in both CP and RCMP are early diastolic wave, that is the E wave, is prominent with a short deceleration time. It reflects predominantly early rapid filling. A very critical difference is the absence of respiratory variation in restrictive cardiomyopathy. Mitral inflow in CP, it demonstrates a respiratory variation of more than 25% with increased in velocities during expiration, that is the left sided filling happens more with expiration, and the mitral E wave deceleration time is decreased and is less than 160 milliseconds. The lack of respiratory variation should not exclude the diagnosis of constrictive pericarditis. Now, this will see the pattern of inflow, if you see, and if you find more than 25% variation in these Doppler signals during inspiration and expiration, and that does confirm or favors the diagnosis of constrictive pericarditis. Of all the echographic parameters, the most important or the most useful is the mitral annular tissue Doppler assessment. The early medial mitral annular tissue Doppler E' velocities are normal or often paradoxically increased in constrictive pericarditis, and that is known as annulus paradoxus. So, if you see sometimes the mitral medial annular velocities are increased in constrictive pericarditis, whereas the tethering of the lateral LV free wall can result in a reverse relationship between the medial and the lateral mitral annular Doppler velocities, that is the lateral cardiac motion is limited in constrictive pericarditis, and therefore here you will have the medial E' higher than the lateral E', and this is known as annulus reversus. Normally it's the opposite, is what's seen. Now, in restrictive cardiomyopathy, there is a decreased E', there is a mitral wall tissue Doppler velocities are reduced throughout. One more finding which we will see in constrictive cardiomyopathy, restrictive cardiomyopathy, is apical. When you see the apical 4-chamber view and a 2-dimensional echocardiography, it reveals this characteristic biatrial enlargement, which is also seen like an owl appearance. And if you see something like this in a 2D echocardiography, it's more suggestive of RCMP. So, to again summarize, there is a respiratory variation which is exaggerated in CP and not in RCMP. Then there is a ventricular wall thickness is usually increased in RCMP. The pericardial thickness of more than 3 to 4 millimeters can be seen in constrictive pericarditis. The atrial size, as I have already mentioned, biatrial enlargement classically in RCMP. The septal bounce, which is very important, is a good sign which will be seen during inspiration and expiration. As I already mentioned, the mechanism which may be present in 2D echocardiography in CP and won't be seen in RCMP. The Doppler E' velocity is increased, the medial, especially the medial one in CP, and they are reduced throughout in RCMP. And if you see the systolic area index, it's greater than 1.1 in CP and it's always less than 1.1 in RCMP. So, I will end the talk with a simple X-ray which sometimes gives a clue or a diagnosis of constrictive pericarditis, where you can see the calcified pericardium. It's very apparent here in both PA and the lateral views. You can see the thin rim of calcium, and it helps us to confirm the diagnosis of constrictive pericarditis. Thank you very much.